Bienvenidos a esta nueva sesión del Webinario Internacional de Educación en Vía Aérea, creado y dirigido por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales, la Facultad de Medicina, en su versión 2022. Este programa está, como les decía, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales, cuyo director es el doctor Ricardo Latrobe Ayuda. Este programa tiene como objeto lograr un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Ustedes pueden acceder a mayor información sobre el programa de nuestra universidad a través de este código QR que les estoy mostrando. Este webinario está apoyado por la Sociedad Europea de Vía Aérea, la EAMS, y también por la Sociedad Española de Anestesiología, Reanimación y Terapéutica del Dolor, CEDAR. La EAMS es una sociedad internacional de origen europeo que agrupa a todos los países del continente, excepto el Reino Unido, que tiene su propia sociedad hace muchos más años, la DAS, y es hermana también de la Sociedad Americana de Vía Aérea. La EAMS tiene dos councils en Latinoamérica, uno en Argentina y otro en Chile. El de Latinoamérica está dirigido por Paula Chiesa y el de Chile está dirigido por mí. Los invito desde ya a hacerse socios, miembros de la EAMS, que tiene varios beneficios para sus miembros, una suscripción a la revista Trends in Anesthesia and Critical Care, y otros beneficios que ustedes pueden ver en pantalla. Hay un descuento especial por la membresía que está aproximadamente la mitad de lo que se paga habitualmente, y ustedes pueden acceder a hacerse socios de la EAMS a través de este código QR. Este año hemos tenido y seguiremos teniendo una constelación de estrellas, expertos todos en vía aérea y en otras áreas, que nos han deleitado y nos han instruido con muy valiosos conceptos durante todo el año, y que vamos a terminar en diciembre, y después el próximo mes a anunciar lo que viene para el próximo año. Aquí tienen ustedes el programa que hemos seguido desde enero. Recordemos que este webinario se inició en enero del año 2021, por lo tanto, en este mes completamos 22 webinarios hechos con diferentes profesores de diferentes partes del mundo. Tenemos el privilegio de tener una traducción simultánea a través de la empresa Traducciones Remotas, que traduce las conferencias al portugués, inglés y por supuesto al español.
Sí, sí.
Los invito a participar, ya sea haciendo preguntas a viva voz. Hay una herramienta de reacciones, ustedes pueden levantar la mano usando esa herramienta y nosotros le damos la palabra, o también pueden hacer preguntas, comentarios, saludos. Nos interesa mucho saber desde dónde nos están viendo, y a través del chat. Así que, por supuesto, los invitamos a participar. Este es el webinario participativo por esencia, así que los invitamos desde ya a participar. Y ahora quiero referirme al doctor Nicholas Chrimes, que nos acompaña gentilmente. Él es un anestesiólogo australiano, trabaja en el Centro Médico Monash de Melbourne, Australia. Es el creador del sistema Vortex para el manejo de la vía aérea difícil no anticipada y de toda una estrategia de ayudas cognitivas para este efecto. Ustedes pueden obtener más información sobre esta importante iniciativa en el sitio web vortexapproach.org, que ustedes pueden acceder a través de ese código QR que ven en pantalla. El doctor Chrimes ha sido un promotor relevante de la utilización de un lenguaje crítico y de la importancia de los factores humanos en el manejo de las crisis de vía aérea. Él es director del proyecto PUMA, Project for Universal Management of the Human. Ha elaborado una estandarización de los procedimientos involucrados en el manejo de la vía aérea con la seguridad como foco primordial. Es cofundadora de Airways, seguro de la vía aérea. El doctor Chrimes ha estado también fuertemente involucrado en la educación médica a través del Centro Médico Monash y el Colegio de Anestesistas de Australia y Nueva Zelanda. Él supervisa el desarrollo y realización de programas educacionales que entrenan a una gran cantidad de médicos en el manejo de emergencias médicas. Es también invitado regular a los congresos que las diferentes sociedades de vía aérea del mundo organizan cada año. Sus contribuciones, tanto en la nuevo conocimiento en la resolución de la dificultad del manejo de la vía aérea como en la docencia, son tremendamente relevantes, por lo que su figura se alza como una de las que más ha aportado en nuevos enfoques en favor de la seguridad del manejo de la vía aérea. Por lo tanto, es para nosotros un tremendo privilegio poder contar hoy día con la presencia del doctor Nicholas Chrimes de Australia, quien nos va a hablar acerca de las guías PUMA en relación a la prevención de la intubación esofágica inadvertida. Antes de darle la palabra al doctor Chrimes, quisiéramos presentar la primera pregunta que le vamos a hacer antes de la presentación. Gabrielita, ¿la puedes mostrar? Esta es la primera pregunta que quisiéramos que ustedes nos respondieran. Si usted dispusiera del equipamiento adecuado, ¿cree que deberíamos usar rutinariamente un videolaringoscopio en cada intubación? Respuestas sí o no. Damos unos minutos para que respondan. No sé si Gabrielita nos puedes ir mostrando las respuestas mientras se van produciendo.
Solo aparece el resultado final
Ya.
cuando lo paro.
Esperemos entonces unos minutos. Yo creo que ahí estamos. Entonces, frente a la pregunta, si uno se dispusiera del equipamiento adecuado, ¿cree que deberíamos usar rutinariamente un videolaringoscopio en cada intubación? Un 58% respondió que sí y un 42% respondió que no. No sé si quieres, Nick, hacer algún comentario sobre esto o después, yo creo, después. Creo que mejor.
Yeah, maybe at the end.
Bien. Perfecto. Entonces, ahora dejo al doctor Nicholas Chrimes para que comparta su pantalla.
Yep. Okay, can you see that now, Ricardo? Oops. Can you see that?
Perfectamente.
Okay. So the next question is going to relate to this case presentation, just a brief case I'm going to outline. So I want you to imagine you've got a fasted, otherwise well patient having an elective general anesthetic. They've had a normal preoperative airway assessment. You've fully pre-oxygenated them, you've induced them, and they've been easy to face mask ventilate while you're waiting for your muscle relaxant to work. And then you perform direct laryngoscopy and get this view. And you're absolutely certain that you see the tube go in. But when you squeeze the bag, you only get this trace, with the amplitude of those CO2 waves being about 3 millimeters of mercury or 0.4 kilopascals. And you scan your monitoring, there's no obvious cause. The capnography is in the circuit. It was working during pre-oxygenation. The patient's got a pulse and a cardiac output and a normal blood pressure. So the question is, given that situation now and that CO2 trace, would you, in the absence of an obvious and immediately remediable cause now, would you pull out the tube at this point?
Gabrielita, ahora muestra la pregunta, por favor. Ahí salimos de la pantalla. Vamos a mostrar la Segunda pregunta. Segunda pregunta. Segunda pregunta es, ¿retiraría entonces usted el tubo traqueal cuando tiene una laringoscopía que muestra la imagen que el doctor Chrimes mostró en su diapositiva? Entonces los invitamos a responder la pregunta. Cuando quieras, Gabriela, muestras las respuestas.
Va en el 65% de participación.
Ahí están las respuestas. ¿Retiraría usted el tubo? 74% respondió sí, 26% respondió no. Volvemos a tu presentación, Nick.
Okay, let me just share my screen again. And you can see that now? Yep. Okay. So firstly, I'd like to thank Ricardo for asking me to present today. It's a great honor to be here. My presentation today is going to be on the recently published consensus guidelines for preventing unrecognized esophageal intubation. And these were produced by the Project for Universal Management of Airways, or PUMA, in collaboration with a lot of the world's major airway societies. Just disclosures, my partner is a former employee of Verathon. For those of you who aren't familiar with PUMA, it's an initiative to create a single set of airway guidelines that can be used independent of the specialty of the clinician, independent of geography, and independent of the context for care. So there's going to be in total 6 guidelines encompassing the complete spectrum of airway management practice, extending from setting up your hospital for airway management right through to performing it and then finally communicating the outcomes of airway management. And those 6 guidelines will be published between now and the middle of next year. What I'm talking about today is none of those. So that's the original project. What I'm talking about today is the guidelines for preventing esophageal intubation. And this was an additional guideline that PUMA took on. We decided to do last year. The most important advice I can give you in this whole presentation is to scan that QR code, download the guideline, and take some time to read it for yourself. If you don't read the guideline, even if you agree with everything I'm saying today, you won't appreciate a lot of the detail, and you will impair your ability to use it effectively to help your patients. So definitely spend some time actually reading the guideline. And really, this presentation is just to give you a bit of an incentive to look at the guideline itself. So this, as I said, this guideline was developed as a supplementary component of the PUMA project, and it came on from what was perceived as an urgent need to develop a systematic approach to the ongoing issue of unrecognized esophageal intubation. So the guideline's been endorsed by multiple by all the major airway societies who contributed to its development, and also by since its publication by multiple other organizations around the world. This is really an unprecedented level of global multidisciplinary consensus for an airway guideline. And there's more organizations listed on the website, and you can scan the QR code to see the supporting organizations there, and more will be added with time. Many organizations are still going. Some have quite complicated processes for formalizing their support. So some haven't been able to provide us with an answer yet, but we'll be adding them as they come. Sorry, my presentation today, what I'm going to talk first about is the incidence of unrecognized esophageal intubation, its etiology, the major recommendations in the guideline, and then if we get time at the end, just briefly talk about how to implement the guideline. Why is that not advancing now? There we go. So incidents, it's difficult to determine the incidents. What's clear to us looking at this is that what we're seeing is the tip of the iceberg, but there's no formalized mandatory reporting of these incidents. And even in Australia, where reporting a death is mandatory, the coroner's court here doesn't necessarily make those public. So we don't necessarily know about all of them. If you extrapolate from NAP4, they only had 9 cases over the 12 months that NAP4 took place. And the incidence of esophageal intubation, if you extrapolate that data, would end up to be about 1 in a million in anesthesia, 1 in 15,000 in intensive care, and 1 in 10,000 in emergency. Now, this is likely to be a gross underestimate. I know, just in the last few months, I know about 3 or 4 cases that have occurred here in the UK that are not part of the published numbers that you hear of through knowing people. So I think what we're aware of is probably a gross underestimate. What you can see there, that the relative numbers are much more common in emergency medicine and intensive care. But the absolute numbers, because 1 in a million sounds like a very low number for anesthesia, but when you think of the number of intubations that go on in anesthesia, that ends up being a sizable amount. So when you look at audits of absolute numbers, there's often similar numbers across different disciplines over a given time period. It's important to remember, whilst it looks more frequent in intensive care and emergency, and it is, that reflects the context rather than the provider discipline. It's easy to sort of say, oh, anaesthetists don't have this problem. It's much more a problem of intensivists and emergency physicians who may not intubate as much. But that data is from the United Kingdom, and most of the intubations in the emergency department in the United Kingdom are done by anaesthetists. So that increase in incidence in emergency medicine in the United Kingdom reflects the change in context rather than a change in provider. The important thing to take away from all of this is that no specialty, no level of experience, and no geographical region is spared from this problem. And it would be a grave mistake to think this is something that only happens to other people. And I know a number of experienced anaesthetists often sort of wipe this off as something, oh, this could never happen to me. It certainly can. If we move on to the etiology, the etiology of unrecognized esophageal intubation is complex. There's technical problems, there's cognitive bias, there's compromised teamwork, and then there are environmental and systems issues. If you want to get an idea of it, if you scan that QR code on the PUMA website, we've summarized a whole lot of cases all the cases we could find of unrecognized esophageal intubation around the world. And it's worth looking at them to get a sense of how this comes about and really think about whether you, in the right circumstances, whether you could be potentially vulnerable to this. And if you look at these cases, there's a number of recurring themes. The first is in relation to the intubation. There is usually a belief that the tube is in the right place. Most of these cases are typically using direct laryngoscopy, but that may just reflect the frequency of its use rather than being necessarily causative. The airway is often not reported as having been challenging, and this might reflect it having been genuinely easy, or it might reflect inexperience and not recognizing anatomy, or it may reflect the tube moving. The other thing it may be is what looks like an apparently easy airway, but is not an easy airway. And this image I showed you before with the case we did at the start, you can easily see why you might think that this is the glottis. In fact, this is a picture of the opening of the upper esophagus. And this is a phenomenon called glottic impersonation, which George Kovacs published on in the Canadian Journal of Anesthesia. And if you look at that image, it's on closer inspection, it's clearly not the glottis. Even though you've got those 2 white lines there and what look like tracheal rings in the middle, the cords are angled the wrong way. There's no arytenoid cartilages. And when you compare it with the glottis above, you can see that it's really not. So we need to be careful and really pay attention to what we're seeing, and not not just stick the tube in the first thing that sort of looks like the glottis, but go to the trouble of clearly identifying the anatomy. And I can say personally, my last esophageal intubation was probably 2 or 3 years ago, and it related to this phenomenon. And when you don't see the two images together, you don't see the glottis and the esophagus together and have that comparison, it's easy to mistake that. So that's probably part of the problem in some cases. The next thing that happens is there's usually an issue with capnography. Either it's not available, it's not used, it's not working or warmed up, or it is there and it's not looked at, or the reading is misinterpreted. And there's been cases where there's been confusion between a pressure waveform has been interpreted as being the CO2 waveform. So there's been no CO2, but the pressure waveform has been misinterpreted as being a positive CO2 trace. There's also been errors in the system that impaired availability, or the ability, or just layout of screens that impair people's ability to see the carbon dioxide trace. And there's often not no trace, but a deteriorating, inadequate, or grossly abnormal trace. And the absence or the abnormality of the trace is rationalized by the team. They find an explanation of why it's okay in that situation to not have what the carbon dioxide trace they would expect. The next thing is that the team usually finds some reassurance with clinical examination. So having put the tube in and been confident it's in the right place, had some abnormality of CO2 or not looked at the CO2 trace, they then perform clinical examination. And that leads them to fall into what we call confirmation bias. Is they look for signs that support what they believe, which is that the tube is in the right place. So the combination of believing it went in the first place, and I definitely saw it go in, is what they think, and then that leads them, when they go to listen to the chest, to hear breath sounds and say, oh yeah, that supports my belief that the tube's in the right place. The carbon dioxide must be wrong. There must be something wrong with the capnography. But it's interesting, when we looked at the cases for putting together this guideline, in the cases of unrecognized esophageal intubation that we looked at, in every case where the lungs were auscultated, breath sounds were always heard. So even though the tube was in the esophagus and the patient died in most of those cases, they always heard breath sounds in those cases. What tends to happen next is having been reassured, being confident that the tube's in the right place, and then being falsely reassured by clinical examination, that they then look for an alternative explanation for the absence of the capnograph. And most commonly, the thing they decide on is that there is bronchospasm or cardiac arrest. And the team tends to become anchored to these diagnoses and fixate on the idea that these are the causes of the abnormality in the capnography trace, and that the tube is actually in the right place. I think another thing that factors into this is their past experience. We're not saying that esophageal intubation is necessarily the most common cause of an abnormal or inadequate capnography trace, but it's certainly one of the most critical ones to exclude. But for most experienced clinicians who don't often perform an esophageal intubation, their experience is probably that other causes are much more frequent, that the last 5 or 10 times they've had a problem with the capnography trace, it's not been due to esophageal intubation, it's been due to something else. So I think experienced clinicians become conditioned to believe that the lack of a normal CO2 trace is something other than esophageal intubation, and that paradoxically might make it more difficult for them to accept the idea that the tube's in the wrong place. Another phenomenon is what's called omission bias. And this is the tendency for us to favour omissions over actions, that we feel less likely for being passive than for taking active steps. For a fear that pulling the tube out might be the wrong thing to do or might cause harm. And probably a fear of criticism for overreacting or panicking. So often what happens now is that the alternative diagnosis is assumed to be the cause of the lack of carbon dioxide, rather than actively demonstrating that the tube's not in the esophagus. At some point in this process, a crisis usually develops, which compounds all of the above. And that's usually either rapidly falling oxygen saturations or cardiac arrest. And ultimately, the association of cardiac arrest with unrecognized esophageal intubation is 100%, because if you're not supplying oxygen to the patient, if you don't address that, eventually the patient arrests. Sometimes when the patient hasn't been paralyzed initially, they've been breathing around the tube that's in the esophagus, and the precipitant for the arrest is the administration of neuromuscular blocking agent, so that when that's given and the patient stops breathing, that's when they desaturate and then arrest. And that often reinforces the idea that this might be due to anaphylaxis. The distraction of the treating the crisis, the hypoxia or the cardiac arrest, or diagnoses such as anaphylaxis, moves the team further away from considering the incorrect placement of the tube as the primary cause of the problem. And then superimposed on this is a lack of teamwork, often compromised leadership, communication problems with role allocation. The team tends to lose situation awareness. Alarm buzzers are hit, a large crowd enters the room. There's typically someone in the room who voices their discomfort with the CO2 trace or queries whether the tube's in the right place, but that's often, that opinion is often dismissed. It's often the airway assistant who says that, or sometimes they describe it afterwards but don't voice it at the time, or aren't heard. There's often impaired clinical thinking and the lack of a structured response. And when you look at the coroner's cases, the word chaos features in multiple coroner's cases of unrecognized esophageal intubation. Recognition of the esophageal placement of the tube often involves another clinician coming in, both to initiate a repeat laryngoscopy or query the position of the tube. But by this stage, often hypoxic brain injury has already occurred. It's interesting, there's no case we reviewed where the repeat laryngoscopy by the original intubator identified the esophageal intubation. Conversely, repeat laryngoscopy by someone else other than the original intubator was a common mechanism for identifying that the tube was in the wrong place. And this probably reflects the person who intubated originally being fooled by whatever issue it was that caused them to put the tube in the wrong place in the first place, and also them being invested in the tube being in the right place and seeing what they want to see. Death often occurs several days later and is followed by coroner's court and coroner's court reports, and often local or systemic change. There's also a second victim here. You know, this is obviously a tragedy to the family and friends of the patient, but team members and the airway operator themselves may really struggle to deal with having made this error and its consequences when they realise they have put the tube in the wrong place and caused the death of a patient. So it's a very serious issue. So that's the etiology. Let me move now on to the recommendations and the guidelines. This is a summary of the key recommendations. It's not all of the recommendations. I'm not going to go through these one by one here. They'll be covered in other parts of the talk. The first thing to say is everything I'm going to say requires, implementing these guidelines requires interprofessional education programs that address not only the technical aspects of correct intubation and identifying esophageal intubation, but also the teamwork aspects of task performance, such as leadership and communication, etc. And this is really a key point that, as with a lot of airway management, it's not just the technical side, but the human factors side is required to implement these guidelines. And that means educating not just the airway operators, but the airway assistants and the whole team. The recommendations can be logically divided into those that reduce occurrence of esophageal intubation and those that promote recognition of esophageal intubation once it's occurred. The recommendations around reducing occurrence are really just an extension of the typical airway guideline recommendations about improving intubation success. So I will talk about them, but I'm going to focus first on promoting recognition, because I think this is the more unique and interesting bit, and also the more challenging part of the guideline. So it won't come as any surprise to you that we advocate always monitoring exhaled carbon dioxide and oxygen saturations during every episode of airway management. We've also advocated that action should be taken to standardize and improve the distinctiveness of the variables on the monitor display. And you can see there on that icon, the idea of shading in the CO2 trace versus not shading in the pressure wave. As I mentioned, the two have been confused in a number of cases. So that's really a recommendation directed at manufacturers, but also at clinicians in looking for, demanding that feature in their monitors when you're purchasing. So talking in a bit more detail about capnography, one of the challenges in relation to capnography is it's not just about there being no trace when there's been an esophageal intubation, but often there's an inadequate trace or a deteriorating trace. And this idea of an inadequate trace is vague and subjective. So what we've done is defined what we've called sustained exhaled carbon dioxide. And this is a specific term with clearly defined criteria required to satisfy whether sustained exhaled carbon dioxide is achieved. And having this clear definition empowers the clinician to remove the tube without fear of criticism by providing a very clear trigger for removing the tube or otherwise excluding esophageal intubation. So the criteria for satisfying, the criteria that need to be satisfied to say that you've got sustained exhaled carbon dioxide are that the carbon dioxide level has to be related to ventilation. The level has to rise during exhalation and fall during inspiration. It also needs to be a consistent or increasing amplitude of carbon dioxide over at least 7 breaths. The peak amplitude of those breaths needs to be at least 1 kilopascal or 7.5 millimeters of mercury above the baseline. And finally, even if all of those criteria are satisfied, the reading has to be clinically appropriate. So it has to make sense. So you could have a reading of 8 millimeters of mercury on exhalation that's sustained. But if the patient's otherwise hemodynamically stable, we normally wouldn't expect there to be such a low CO2. So in that situation, the reading wouldn't be clinically appropriate and the criteria still wouldn't be satisfied. Once evaluating those criteria, what we recommend is that following each intubation, both the airway operator and the airway assistant should independently assess the carbon dioxide trace and the oxygen saturations and assess and verbalize whether sustained exhaled carbon dioxide and adequate oxygen saturations are present. So this is a 2-person check for the presence of sustained exhaled carbon dioxide and adequate oxygen saturation. So what happens if there's not, if the criteria for sustained exhaled carbon dioxide aren't satisfied? So obviously, if you look around and you see that the capnography hasn't been put into the circuit, there's been something disconnected, then you can address that, restore sustained exhaled carbon dioxide and move on. But in the absence of an obvious and immediately remediable cause for the absence of sustained exhaled carbon dioxide, then esophageal intubation needs to be actively excluded. And that's where we move to the algorithm of these guidelines. So this is the algorithm, and the basic architecture of the algorithm is that it's composed of 4 questions down the middle there. The first is removing the tube dangerous? The second is, are the oxygen saturations adequate? The third question is, has esophageal intubation been excluded? And the final question is, has sustained exhaled carbon dioxide been restored? If the answer to any of those 4 questions is no, then the tube needs to be removed. But not just removed. So this is not just if you're unsure, pull it out. This is even if you're certain it's in the right place, you pull it out. Removing the tube is the fastest, simplest, and most definitive way to exclude the possibility of esophageal intubation. But as I was saying, it's not just about removing the tube, but removing the tube and attempting ventilation with a face mask or a supraglottic airway. because whether you get CO2 back with a face mask or supraglottic airway is crucial for situation awareness. So if you haven't had CO2, haven't had sustained exhaled carbon dioxide with intubation, but when you go back to face mask or supraglottic airway ventilation, you get a CO2 trace, that immediately tells you that this is not a patient cause or an equipment cause for the inadequate CO2 trace. This is a problem with the tube. Not necessarily esophageal intubation, it could be a blocked tube or a leak around the cuff, but it tells you that the tube is the problem. And that means that if you subsequently re-intubate and the tube and CO2 disappears again, that tube needs to come out again. Now that's very different from what your interpretation might be if you didn't perform intervening face mask or supraglottic airway ventilation. If you just pull the tube out because there's not an adequate CO2 trace, and then you have a look down again and you think, no, that's definitely the cords, and you put the tube back in to what you think is the right place, and again, you don't get CO2, then most of us would interpret that as meaning, well, I've put it back, I've checked it's in the right place and I still don't have CO2. I've eliminated a tube problem. It must be a patient or a equipment cause, which is the opposite conclusion. So that ventilating in between removing the tube with a face mask or supraglottic airway and seeing if you get CO2 with a face mask or supraglottic airway is a very important step, and I think is a unique step that's not been emphasised in previous attempts to address the problem of unrecognised esophageal intubation. It's only when all four of those questions have been answered yes that you're able to leave the tube in. Over on the left here, you'll see what we call the quick check. This is performed in parallel with working through those four questions and excluding esophageal intubation. And what the quick check does is prompts the team to consider causes of absent sustained exhaled carbon dioxide other than esophageal intubation. So ultimately, this is not just a suspected esophageal intubation algorithm, but an inadequate carbon dioxide algorithm, because inadequate carbon dioxide is the clinical problem you're going to get presented with in this situation. So let's look at each of those four questions in the algorithm in a bit more detail. The first is removing the tube dangerous? In 99% of the cases, the answer to this question will be no. Really, two criteria need to be met for it to be considered dangerous to remove the tube. There needs to be a likelihood of serious harm from removing the tube, and there needs to be a reasonable basis for believing that the tube's in the trachea in the first place, despite a lack of sustained exhaled carbon dioxide. Most of the time, and certainly most of the cases we've looked at of unrecognised esophageal intubation, removing the tube would not have been dangerous, and simply ventilating with a face mask or supraglottic airway would not only have restored oxygen delivery and made the patient safe, but would have also confirmed that CO2 was present and that there was a problem with the tube, and then directed the team to address that. There's really only probably two main reasons that there might be a likelihood of serious harm from removing the tube. And the first is if you have a reason for believing that face mask or supraglottic airway are very likely to be unsuccessful. It's not intuitive, but if you think about it, it's actually irrelevant whether you think that whether intubation was difficult. Because if intubation was challenging, then that makes it more likely that the tube's in the right, that the absence of sustained exhaled carbon dioxide is due to esophageal intubation, and therefore would encourage you to pull it out. Conversely, if you thought the intubation was straightforward and you had a good view, then that tells you that if you remove the tube, it's going to be easy to put back in if you need to. So again, that should lower your threshold for removing the tube. So whether or not the intubation was difficult is not really the question. It's really about whether face mask or supraglottic airway ventilation are likely to. So unless they're highly likely to be unsuccessful, it's probably not going to be dangerous from that point of view. The other thing that might make it dangerous is if there was a very high risk of aspiration. And we wouldn't expect that every indication for rapid sequence intubation would satisfy this, but if someone has a small bowel obstruction with a lot of gastric content flooding up into the airway, in that situation, it might be legitimate to say that removing the tube would be dangerous. The second question is whether the oxygen saturation is adequate. And this is really important for a couple of reasons. The first is that if oxygen saturations are, sorry, if the oxygen saturation is not adequate, if the oxygen saturation is inadequate or falling in combination with absent sustained exhaled carbon dioxide, that really means that the likelihood of esophageal intubation is much higher. Makes it much higher. If you've got absent sustained exhaled carbon dioxide and falling oxygen saturations, then that really adds weight to the idea that esophageal intubation is likely to be the cause. It's also important because the falling oxygen saturation is what causes harm to the patient. So being conscious of the oxygen saturation, which again has not historically been something that's been emphasized in approaching unrecognized esophageal intubation, is something we've been very, very conscious of, because when patients come to harm from unrecognized esophageal intubation, it usually requires not just that the team has not addressed the absence of sustained exhaled carbon dioxide, but also that they've not addressed prolonged or profound hypoxemia. The next question, my slide's not advancing for some reason, hang on. The next question is, hang on, that's gone backwards. Whoops, hang on, what was I going to the other thing to say about if the oxygen saturation is not adequate is that regardless of whether the tube's in the right place or the wrong place, if the oxygen saturations are falling or inadequate, you're not supplying the oxygen to the patient anyway. So removing the tube is very likely to, or you're not supplying adequate oxygen to the patient. So removing the tube is very unlikely to be harmful. So if in the situation where you consider that removing the tube is dangerous, then whilst the oxygen saturations are preserved, you've got the opportunity to use alternative techniques to exclude esophageal intubation. And so actively excluding esophageal intubation doesn't just mean finding another potential explanation for why you don't have sustained exhaled carbon dioxide. It's demonstrating the tube is not in the esophagus using specific criteria. And what we talk about is using valid alternative techniques. And those are repeat laryngoscopy, use of a flexible bronchoscope, use of ultrasound for those who are adequately skilled in its use. And that final icon there is supposed to be an esophageal intubation, esophageal detector device, which I'll show you a picture of in a moment if you're not familiar with it. And what we recommend is a 2-mechanism check whenever feasible. So that firstly, a repeat laryngoscopy plus one other supplemental technique. So the reason we advocate repeat laryngoscopy first is that repeat laryngoscopy will always be something that the intubator can do immediately. If you've just intubated the patient, you'll have a laryngoscope with you and you'll be able to immediately perform a repeat laryngoscopy. Ideally, we'd like this to be with a video laryngoscope, but if you don't have that immediately available, we'd suggest that you do it immediately with a direct laryngoscope and then repeat it once a video laryngoscope's available. Because there are a number of ways that the repeat laryngoscopy, so if repeat laryngoscopy identifies clearly that the tube's in the esophagus, then obviously the tube comes out. But if the repeat laryngoscopy is reassuring, then because repeat laryngoscopy can sometimes be falsely reassuring, we recommend confirming it with a second technique whenever feasible. Just to talk about repeat laryngoscopy a little bit more, we've identified a number of criteria for performing it properly for it to be a valid alternative technique. So I've already mentioned the use of a video laryngoscope whenever feasible. Also, the most expert immediately available practitioner should perform the repeat laryngoscopy, and performing it according to strict criteria. So not just having a quick look to see if I think I can see the tube going through the cords. It's not always clear whether on a repeat laryngoscopy whether the tube's in the right place, because the tube itself can impede the view or impede correct positioning of the blade. So you might not always get a good view. You could look at that picture and I'll leave you to decide whether you think it's in that tube if you did a repeat laryngoscopy and got that view, whether you'd be comfortable saying that tube is in the right place. There's a little bit of white there on to the left of the tube that you could argue is the cords. That tube is actually in the esophagus. So by our criteria, we'd say that if you did a repeat laryngoscopy and got that view, you wouldn't be able to exclude esophageal intubation. And so you would be dependent on your second technique there. So that would be a indeterminate outcome for repeat laryngoscopy. So to get around this, so what we ask is that people look to see the tube on their repeat laryngoscopy. They deliberately look to see the tube passing between the cords and anterior to the arytenoids, and there you ideally bilaterally. And there you can see, if you look between the cords, it's not clear whether that's really the cord on the left there, and it's clearly not because that tube's in the esophagus, but it looks like it could be. But also, if you go to see the tube passing anterior to the arytenoids, you can see there are no arytenoids there. So for those reasons, that wouldn't satisfy our criteria for excluding esophageal intubation on repeat laryngoscopy. So really what you want to see is this: the tube passing between the cords and passing anterior to the arytenoids, ideally bilaterally. There was, as I mentioned earlier, there's no case where repeat laryngoscopy by the original intubator identified the esophageal intubation. So what we advocate is that an independent second person also check. So we're not saying the original intubator, because there might not be a second intubator there initially. We're not saying the original intubator shouldn't have a look initially, but as soon as someone else comes, they should verify the repeat laryngoscopy and see whether they think it's in the right place too. So they're the criteria we're looking at for repeat laryngoscopy in order for it to exclude esophageal intubation. It's still vulnerable to getting a falsely reassuring result. So because of that, as I've said, whenever possible, we advocate a second mechanism check. And so that can be with a flexible bronchoscope, looking to see the carina and the tracheal rings and the trachealis muscle posteriorly, with the tip of the tube in the foreground. For people experienced using ultrasound for this technique, they can look for what's called the double tract sign, or the absence of the double tract sign. The double tract sign indicates an esophageal intubation. They can also look for lung sliding. And finally, this is the esophageal detector device, which I mentioned before, which if you put it on the end of the tube and squeeze it, if it's in the lungs, because the trachea is rigid walled and the lungs are filled with air, the bulb on that tends to just refill. If it's in the esophagus, because the esophagus is soft walled, the negative pressure when it tries to re-expand collapses the walls of the esophagus, and it doesn't re-expand. It sounds like a very basic technique. It's actually got a high, not perfect, but a high accuracy for detecting whether the tube is in the trachea or in the esophagus. Unfortunately, these aren't widely available in a lot of countries at the moment, and it's something that the PUMA group is working to talk to industry to try and get them manufactured. They used to be very widely available and were commonly used in a pre-hospital setting, but as capnography has become more accessible in pre-hospital, they've sort of fallen out of use, but not because they weren't reliable, but because they were that just replaced by something better. But when you're not getting a CO2 trace, they're quite a good technique. And I think what I'd like to see happen is that we get these made available. They're quite cheap, and they could be in every anaesthetic trolley. And the minute you don't get CO2 and find yourself in a situation where you think it's inappropriate to pull the tube because it's dangerous, that you could connect that and get probably a very high, highly accurate result of whether the tube's in the esophagus. There are some caveats. There are some specific circumstances in which they're not accurate, but there's certainly something that's worth having available. So that's the techniques for excluding esophageal intubation: repeat laryngoscopy plus, whenever possible, one of those other three techniques in combination. And if that doesn't exclude esophageal intubation, then the tube needs to be removed. The final question, very important to note there, is what you can't do to exclude esophageal intubation is use clinical examination. Clinical examination should never be used to exclude esophageal intubation. And the reason for this is it's simply not capable. It doesn't have the discriminatory value, the discriminatory ability to determine whether the tube is in the trachea or in the esophagus. So, as I mentioned earlier, in the cases of unrecognised esophageal intubation we reviewed for the guideline, when the lungs were auscultated, breath sounds were heard in 100% of cases. And this probably relates partly to a limited ability to distinguish between esophageal or gastric breath sounds and pulmonary breath sounds, but also due to that bias in the person listening, in that they want to believe that the tube's in the right place, so they hear what they want to hear. Tube misting, which we often, I don't know what it's like in your practice, but certainly in mine, our trainees often, as soon as they intubate, they ventilate and they see the tube mist, and they tend to recite the tube is misting as a reassuring thing. Presence of tube misting means that there's about a 50-50 chance of the tube being in the trachea. Conversely, the absence of tube misting strongly suggests esophageal intubation. So if you don't have tube misting, that's very suggestive that the tube is in the esophagus. But if you do see tube misting, it really tells you nothing at all. So I would encourage you to stop your trainees sort of reciting that. They could certainly verbalise if they don't see tube misting, but there's really no value in them saying that they do, because it falsely conveys that that's a reassuring sign, which it's not. So we're not saying not to use clinical examination at all, but we're saying using clinical examination safely and correctly is about knowing its purpose and its limitations. Don't use esophageal intubation to exclude, don't use clinical examination to exclude esophageal intubation once it's suspected. It might be used to increase your suspicion of esophageal intubation. It might make you suspect it, but it can, basically, clinical examination can encourage but should never discourage removal of the tube. So the final question is whether sustained exhaled carbon dioxide has been restored. So unless sustained exhaled carbon dioxide has been restored, the tube needs to be removed. So, and this allows for that small false negative rate even with devices such as the esophageal detector device. If you were to get a falsely reassuring result with the esophageal detector device, but the tube was actually in the esophagus, then you wouldn't be able to restore sustained exhaled carbon dioxide, and ultimately you would still need to remove the tube. But if the test to exclude esophageal intubation has been correct, then restoring sustained exhaled carbon dioxide means identifying and addressing causes of its absence other than esophageal intubation. And for that, we turn to the quick check prompts, which I mentioned before. And as I said, this is a parallel process that goes on at the same time as you're working through those 4 questions we've just talked about. There are lots of potential causes for absent sustained exhaled carbon dioxide other than esophageal intubation. So you need to have an efficient method for evaluating these. Working through them quickly is important for 2 reasons. The first is many of them indicate that you're not ventilating the patient. So they might also be time critical to identify. The second is even the ones that aren't time critical to identify, things like a monitoring problem where you might still be ventilating the patient. In the situation where you've determined that removing the tube is potentially dangerous, then identifying these rapidly might prevent you unnecessarily removing the tube if the patient desaturates, because you're able to restore sustained exhaled carbon dioxide. So to move through these quickly, we've developed the quick check. And this is really, I think it's probably equivalent to the idea of, I don't know whether it translates well into Spanish. In English, we talk about the H's and T's for cardiac arrest, which are hypovolemia and hypoxia and tamponade and tension pneumothorax, those other causes of cardiac arrest. And so this is really a way to quickly work through the other causes of esophageal intubation, of absent sustained exhaled carbon dioxide other than esophageal intubation. And basically it works out that there are 2 equipment causes, 2 airway causes, and 2 patient causes for absent sustained exhaled carbon dioxide. So let's start with the equipment causes. The first is obviously carbon dioxide, that you're monitoring malfunction. So just confirm that your carbon dioxide detection device is working. The second is issues proximal to the tube, so issues with your anesthetic circuit. There's lots of potential issues proximal to the tube, but they can all be eliminated by simply removing all the equipment proximal to the ETT connector and then connecting a new filter or whatever your circuit adapter for the CO2 is with your recently checked CO2 detection device attached to it, and then connecting that to a new self-inflating bag. So that means that everything proximal to the tracheal tube has been checked, and you know the capnography works. So if you still don't have CO2 at that point, you know that it's not an equipment problem. It must be a tube or a patient problem. In terms of airway problems, other than esophageal intubation, you can have a leak around the tube. So assessing to see if you can hear a leak, putting some more air in the cuff. If you've got a pediatric patient with an uncuffed tube, then you may need to remove the tube anyway to fix that, or you could put a throat pack in to try and decrease a leak if you detect that and you didn't want to remove the tube. It could also be a blocked tube. So you can pass a suction catheter or a bronchoscope down the tube to assess the tube patency, remembering that the ability to pass a catheter or a bronchoscope down the tube, if it won't go down, then that confirms the tube's obstructed. But if you have viscid secretions or blood clot or vomitus in the airway, it is possible that you can't ventilate past that, but that you can pass a tube past it. So it doesn't, passing a suction catheter down the tube or a bougie down the tube doesn't exclude a blockage to the tube. Even passing a bronchoscope down, there are cases reported where they passed a bronchoscope down, and despite visualizing the tube, there's been a bit of a flare that they hadn't noticed, and they haven't seen the blockage, but when they've removed the tube, there's actually been a substantial blockage to the tube. So assess the tube patency. It can confirm whether the tube's blocked, but it can't exclude it. Finally, patient causes. This is particularly important because these are the two most common alternative diagnoses to which teams tend to become anchored in cases of unrecognized esophageal intubation. So you need to know how to exclude them. But important to say, these are unlikely explanations for the absence of sustained exhaled carbon dioxide. And the reason is this. Bronchospasm is often used as an explanation for sustained exhaled carbon dioxide, but in nearly all the cases where it's used, the clinicians identify bronchospasm as the reason that there's no carbon dioxide, but they then reassure themselves by hearing good breath sounds when they auscultate the chest. And I think in the stress of managing a crisis, they seem not to recognize the contradiction involved in that. If you're moving enough air, the reason bronchospasm gives you the reason bronchospasm might cause an absence of sustained exhaled carbon dioxide is because you're moving no air. If you're moving enough air to get breath sounds, then you should have sustained exhaled carbon dioxide. You should have carbon dioxide return. Certainly, if you have true, very tight bronchospasm where you can't squeeze the bag at all, that might produce absent sustained exhaled carbon dioxide, but it can't be assumed to be, and you still have to exclude esophageal intubation. But what we advocate doing is ensuring that you've got adequate inspiratory pressure and adequate expiratory time. Certainly watching anaesthetists in simulations of bronchospasm or anaphylaxis where there's high airway pressures, what they tend to do is they squeeze the bag, it's very tight, and then they open the APL valve and until the bag feels normal and ventilate, and then they don't get CO2 because they've created a low pressure pathway into the scavenging system of their anesthetic machine. And so the reason they're not getting CO2 is because they're not ventilating the patient. So actually doing the opposite of that and cranking that pressure valve or your PEEP valve right down and generating a high pressure and then giving adequate time for the lungs to empty even in severe bronchospasm, in most cases, you should get a CO2 trace. In respect to cardiac arrest in the presence of external cardiac compressions should nearly always give you sustained exhaled carbon dioxide. So if you're suspecting cardiac arrest, check the pulse and start compressions if necessary. So it's important to realize that bronchospasm, if you have evidence of air movement and cardiac arrest in the presence of cardiac compressions, are not only unlikely causes, they're actually implausible explanations for the absence of sustained exhaled carbon dioxide. It's not reasonable to use bronchospasm with evidence of air movement or cardiac arrest in the presence of cardiac compressions as an explanation for the absence of sustained exhaled carbon dioxide. In those situations, something else must be going on, and you need to look for that and exclude esophageal intubation. There is one more set of causes under the quick check, and one more patient causes. One more set of patient causes. These are very context specific. So they're things like a massive tracheoesophageal fistula or a bronchopleural fistula, anterior mediastinal mass, tracheal obstruction distal to the tube, or bilateral bronchial obstruction. All of those things might cause absent sustained exhaled carbon dioxide. They're usually things that are quite context specific, and so they should be considered as appropriate to the context. So that's the algorithm, both the 4 questions down the middle and in parallel with that, the quick check to look for. So the 4 questions down the middle to really look at excluding esophageal intubation, and the quick check down the left there performed in parallel to look for causes of absent sustained exhaled carbon dioxide other than esophageal intubation. At the end of that, if sustained exhaled carbon dioxide can't be restored, then the tube needs to come out and ventilate with an alternate device. So that's the recommendations on promoting recognition. I'm going to quickly, before we finish, briefly talk about the recommendations directed at reducing the occurrence of esophageal intubation, so preventing it happening in the first place. So we recommend that the airway operator should verbalize the view at laryngoscopy. So either using a commonly understood classification like Cormick and Lehane, or preferably just describing the anatomy. I can see the epiglottis, I can see the vocal cords, I can see the arytenoids. And the reason I say that's preferable is for the reason I said before, is that it forces the airway operator to focus on specifically identifying the anatomy rather than getting complacent and just putting it between 2 white things and assuming that what might be glottic impersonation is mistaking that for actually being the glottic opening. Verbalizing the view also provides the opportunity for other members of the team to query the view if a video laryngoscope is being used. So if someone's misidentified the larynx, it provides another member of the team the opportunity to query whether what they're seeing is actually the larynx. Verbalizing the view also provides a shared mental model to the team around what the challenges involved with intubation are. And this is particularly important if video laryngoscopy is not available and the team can't see for themselves what the view is, that telling them what the view is. The rest of the team knowing what the view is empowers them to encourage tube removal if there's not adequate sustained exhaled carbon dioxide. For the reasons I said earlier, if there's an adequate view, if it's been a straightforward intubation, then the tube can be removed on the basis that reintubating should be straightforward. If there's been challenges getting a view, then removal of the tube can be encouraged on the basis that a challenging intubation and then the absence of sustained exhaled carbon dioxide makes esophageal intubation more likely. We advocate routinely using a video laryngoscope whenever feasible. And so this is a first line technique whether you're anticipating challenges with the airway or not. Now, I acknowledge that for many, if not most contexts at the moment, there's not adequate equipment to do this. But another recommendation we've made in relation to this is that if you don't have the ability to implement this immediately, that what you should do straight away is set out a plan and a timeline for achieving it. And that means going to administration to get the equipment. So part of the intention of this recommendation is not just is obviously to get people to use video laryngoscopy, or use a video laryngoscope, I should say, for their intubation, but also to empower clinicians to go to administration and request funding for this equipment, to say, this is a guideline now that recommends routine use of a video laryngoscope for every case, that has been endorsed by all the major airway societies around the world and a lot of other organisations. And hopefully that provides leverage that will allow people to get access to more video laryngoscopes. I don't think this is really a controversial recommendation. I think it's just something that the time has come. We're not the first to say it. The Canadian Airway Focus Group in their guidelines last year advocated routine use of a video laryngoscope. It's now just being said with the backing of all these organisations and endorsing bodies. Using a video laryngoscope improves the view. It decreases the incidence of esophageal intubation. It decreases the number of attempts. It increases success. It leads to less hypoxia. It leads to less trauma. It improves teamwork by allowing the assistant to anticipate the needs of the airway operator, to prepare equipment and to help them intervene. It also allows them, as I've mentioned, to confirm or challenge or query the view that's been obtained. For training, video laryngoscope, there's evidence now that using a video laryngoscope before direct laryngoscope can improve the learning curve, can be used to teach in real time, and allows you to give trainees a longer leash, if you like, and allow them to solve problems and optimize them yourself while the consultant or senior can supervise them and know whether it's okay for them to step in without putting the patient at risk. This is the most recent Cochrane review, which goes through a number of those issues and demonstrates a substantial decrease in the incidence of esophageal intubation with use of a video laryngoscope. A few common objections to use of a video laryngoscope: cost. Certainly that can be a big issue in low resource settings. In high resource settings, I think it's probably not a particularly legitimate answer. It's often just, it's not that the money's not there, it's where it's being distributed to. If you, certainly in my practice, the surgeons have their 4K screens to do laparoscopies. They're using staple guns and all sorts of things that are very expensive. The money's there if you can get the organisation to perceive that it's needed to be there, and we hope that guideline will be of value to clinicians in trying to get that money distributed to you. Obviously, as I said, in lower resource settings, there's genuine issues with getting access to video laryngoscopes. Often environmental concerns are raised with video laryngoscopy. Because of the use of, I think a lot of people certainly in Australia, got a lot of access to video laryngoscopes during COVID when we're using recyclable blades, using disposable blades. Those disposable blades actually are recyclable for many of those, for many manufacturers, but there's often not processes in place to recycle them. So, if you're using disposable blades, you can try to set up mechanisms to recycle them. But also just using a video laryngoscope doesn't mean using a disposable blade. You can just use a reusable blade. There's a common myth that video laryngoscope doesn't work well in the soiled airway. Even if it doesn't, even with a Mac video laryngoscope, if the video part of it doesn't work in a soiled airway, you've only reduced it to being a direct laryngoscope, which is what you're going to use anyway. So you're certainly no worse off using a Mac blade video laryngoscope. At worst, if there's soiling impairs the video view, it just becomes a direct laryngoscope. So you might as well have the potential to get an indirect view. But This study by John Sackles in the United States has demonstrated quite clearly that a soiled airway does impede your view in both video laryngoscopy and direct laryngoscopy, but the superiority of the view with a video laryngoscope is maintained even in the presence of a soiled airway. People often concerned that they're going to de-skill by using a video laryngoscope all the time. The recommendation is to routinely use a video laryngoscope, not necessarily use video laryngoscopy. So there's nothing stopping you using a video laryngoscope to perform direct laryngoscopy and having access to the indirect view on the same attempt if you find that challenging. So we're not saying you have to give up direct laryngoscopy. What we're saying is that if you perform direct laryngoscopy, you should be performing it with a device that is also capable of performing indirect laryngoscopy. I actually think a lot of the reluctance to give up video use, to routinely use a video laryngoscope is based on ego. I think a lot of people, a lot of airway operators, where it is a badge of honor, they see this is a difficult patient, but they think I can get this done. And I think we just need to move past this now. The important thing is the safety of the patients. And what I would ask is to ask yourself, if you are opposed to using a video laryngoscope routinely, how does that benefit your patient not using a video laryngoscope? Just before I wrap up, I just want to emphasize the role of the airway assistant in these guidelines. We've advocated that they can query the view, that their role in that two-person check to verbally confirm the presence of sustained exhaled carbon dioxide and adequate oxygen saturations. That if someone says that removing the tube is going to be dangerous in a circumstance where it really wouldn't, they're able to challenge that. That according to the algorithm, they can prompt the operator to remove the tube if it's not dangerous to remove it, or if the patient desaturates. They can be there to observe the outcome when the tube's not removed of valid alternative techniques, or repeat laryngoscopy if it's done with a video laryngoscope, or of bronchoscopy, or the esophageal detector device. And if the team is starting to rely on clinical examination, they can challenge the use of clinical examination. So the role of the airway assistant, and where I really started was saying the importance of a team approach. This is very important. And I'll just come back to that first point I made, that implementing these guidelines, it's really crucial that we have interprofessional education programs that address both the technical and team aspects of preventing unrecognized esophageal intubation. Very quickly, I'm just going to show a quick slide on implementation. Implementing these guidelines is a substantial effort. You need to print out the cognitive aid, the cognitive aids, including the algorithm, and put them in all your operating theatres or anywhere where you would be performing airway management. You need to roll out education programs, multidisciplinary education programs for both airway operators and airway assistants, and ideally be doing that as a combined education session with both present. There's culture change required to empower the nurses to participate in the two-person check, and also cultural change to encourage the universal use of a video laryngoscope for every intubation. We need to lobby for access to sufficient video laryngoscopes. We need to lobby industry for getting an esophageal detector device. We need to standardise the monitor layout, and that requires lobbying industry to make changes to the way the pressure and CO2 waveforms are displayed on monitors. And finally, one of the big areas where capnography is not well used is in neonates. And we really need to start encouraging use of capnography in neonatal intubations. And that's the end. So I'll open it up to questions. Back to you, Ricardo.
Muchas gracias por tu extraordinaria conferencia. Creo que me pareció muy importante la lectura de este texto. De hecho, para promocionar este webinario, enviamos el enlace de este artículo que tú escribiste junto con otros coautores, para que quienes que estuvieran interesados en esta charla pudieran tenerlo a primera vista. Quiero ante todo dar la palabra para que los participantes puedan hacer sus preguntas o comentarios. Solo tienen que levantar la mano usando la herramienta de reacciones en la parte baja de la pantalla. Tenemos un mensaje del doctor Juan Carlos Mandujano desde México. Dice, primeramente agradecer la plática por parte del doctor Nicolás, además de agradecer la elaboración del sistema Vortex. En los años que tuve con asistencia de residentes, fue algo que me permitió compartir lo aprendido y poder de alguna forma sistematizar la enseñanza en el manejo de la vía aérea, en especial en la técnica más difícil de lograr por algunos, la ventilación adecuada y el no aferrarnos a la intubación. El doctor Mandujano está pidiendo la palabra. Adelante, Juan Carlos.
Gracias, Ricardo. Muy buen día para todos. Al doctor Nicolás, muy buen día. Y nuevamente es agradecer este tipo de webinarios que nos permite reforzar aprendizajes, compartir aprendizajes y experiencias que vamos viviendo. Es muy importante, como menciona, la aplicación de algoritmos, de guías, de directrices. Creo que tristemente podemos continuar viendo que a nivel mundial seguimos enfrentándonos a un gran problema, que es el poder aplicarnos a estas directrices, ya que en muchos sitios se sigue sin contar a veces con lo más básico. El día de ayer comentaba algo muy adecuado al momento con un exresidente que ya ahorita está como médico adscrito en una institución de la Secretaría aquí en México, que es el IMSS, el cual me decía que tuvieron una vía aérea difícil, que se le presentó la dificultad cuando vieron que iba a estar programada la paciente. Le dicen, es difícil la paciente, pero sus compañeros que la habían manejado antes no le pasaron la información completa de las características de la paciente, solamente le dijeron que hicieron 3 intentos y desgraciadamente en este hospital que es del IMSS o del Instituto Mexicano de Seguridad Social, no cuentan con un videolaringoscopio como parte de la institución, lo que hemos mencionado en otras ocasiones, ¿no? Que desgraciadamente muchas veces recae sobre uno mismo el estar comprando equipamiento para poder ofrecerle algo de seguridad a los pacientes. Vivimos la circunstancia de que a cada momento nos hablan de las guías internacionales, del artículo de errar es humano, pero esa parte donde las instituciones se han deslindado y dejan como responsabilidad para cumplir una seguridad para el paciente sigue siendo manejada y absorbida únicamente por el personal anestesiólogo, por el de urgencias, por el de terapia, por cada uno de los que nos enfrentamos a este tipo de pacientes. Y entonces es un sitio que se vuelve con pocos recursos o sin recursos y que las directrices, pues la parte a veces más difícil de poder cumplir, por muy buenas que sean, es la situación de no contar con esos recursos de manera inmediata para poder ofrecer realmente lo que queremos todos, un manejo de vía aérea seguro. A este residente, pues nuevamente le confirmé, o a este exresidente le confirmé, ya que tú necesites, con todo gusto, tú me invitas, digo, obviamente, si se trata de un procedimiento que no sea de urgencia, como para poder desplazarme los 30, 40 minutos de viaje, y con todo gusto platicamos, hacemos talleres, refortalecemos las diferentes técnicas, y esa parte importante que menciona el doctor Nicolás acerca de la falta de comunicación efectiva dentro de los equipos. Él me decía, este reciente, que dice, bueno, pues mi jefe de servicio, ya un médico con experiencia, me dijo que una de las alternativas que él hacía ya con el paciente en posición era, para facilitar el desplazamiento del tubo, era levantar de las piernas, algo que a mí me sonó muy ilógico. Dice, pero no voy a desestimar la experiencia de él. Digo, bueno, ¿y qué pasó? Pues finalmente le levantaron las piernas y no sirvió absolutamente para nada. Él trató de seguir directrices y donde vemos aquí esa parte importante es, él fue uno de los que tuvo suerte, de alguna forma él mismo lo menciona, de haber estado con alguien que ya tenía un poquito más de tiempo recorrido en manejo de vía aérea, pero todos los que no tenemos esa oportunidad o que no han tenido esa oportunidad, se vuelve realmente crítico porque pues cuando lleguemos a un hospital, la situación real es que la gente que nos va a abordar ahí no es un anestesiólogo. En muchos hospitales, así como menciona el doctor Nicolás, solamente la vía aérea se maneja o se vería manejado obligadamente por el anestesiólogo hasta que estamos en una situación de paro, en piso, en tomografía, en rayos X. Mientras es el personal de urgencias, el personal médico de medicina interna del piso, y nosotros nos hemos concretado a veces estar solamente en el quirófano. Entonces, la tarea sigue siendo muy grande. Creo que debemos buscar generar un impacto que realmente sea mayor a que obligue a los hospitales a nivel mundial, y ese serviría tal vez trabajando a través de presionar a la OMS como un organismo no solamente médico, científico, sino como un organismo político que puede en un momento dado presionar a mayor cumplimiento de estas directrices, y eso facilitaría el camino para muchos compañeros en un futuro. Muchas gracias, y al doctor Chrimes, muchas gracias nuevamente por el sistema Vortex. Es una idea buenísima que se puede aplicar en distintas áreas de cualquier hospital.
Thank you. I'll just in relation to your comment about difficulty implementing the guidelines through lack of equipment, a lack of access to video laryngoscopes. I think that is an issue, not only in low resource settings. I think it's an issue in probably most anaesthetic departments probably today, even in high resource settings, don't have the equipment to do that. For high resource settings, I think it's probably an issue that can be addressed in the next 6 months, assuming there's no sort of supply chain issues. For lower resource settings, it may take several years, but or longer. But I think we've been very conscious of that, and that recommendation is to use that where feasible. So we've acknowledged that it won't be feasible for some people, certainly not immediately, and that's been a very deliberate phrase to make sure that the guidelines don't alienate certain groups that can't do that immediately, that they still feel that these are applicable to them, and that certainly the rest of the recommendations are relevant, and that and as I said, that if they can't do it at the moment, that they can at least try to make a plan and go to administration to work out, well, we can't do this, but what is our strategy, so that at least the process is set in motion.
Exactamente. Muchas gracias, doctor Mandujano, por su comentario. Yo invitar a todos a hacer preguntas y comentarios a través del chat o levantando la mano. Tenemos muchos residentes dentro del público, incluso grandes expertos como el doctor Luis Gaitini, que nos está viendo desde Israel, y otros más que estoy viendo en este momento. Yo quisiera comentarte, Nick, acerca de un concepto que yo he tenido hace mucho tiempo y que se basa básicamente en que la laringoscopía no es lo mismo que la intubación. Y eso me parece que es válido tanto para la laringoscopía directa como la indirecta. Y el otro concepto es que la laringe es una estructura móvil, por lo tanto, posiblemente, como una estrategia de reducción de la ocurrencia de la intubación esofágica, sea recomendable el uso de la manipulación externa de la laringe, antigua maniobra de Burke, acuñada por Richard Neal, en que esta manipulación externa de la laringe no solamente permite mejorar la laringoscopía, sino que además puede estabilizar la laringe, que eso, como decía, es una estructura móvil. De esta manera, cuando uno introduce el tubo con la intención de intubar la tráquea, muchas veces, y especialmente cuando no tiene uno una buena laringoscopía, es posible que el tubo impacte en alguno de los cartílagos de la laringe y se desvíe inadvertidamente hacia el esófago. Por lo tanto, es posible que estabilizando la laringe de esta manera se pueda evitar o disminuir la incidencia de la ocurrencia de esta intubación esofágica. No sé qué te parece, esta es una idea que yo la he enseñado hace mucho tiempo a mis residentes y colegas, y que posiblemente me parece razonable, por lo menos a mí, pero me parece que es muy importante tu opinión como líder de esta iniciativa de PUMA para evitar la intubación esofágica inadvertida.
Yeah, look, I think certainly that the problem of the tube not going where you intend it to go is a contributor to this issue, and so I think what you're saying is valid. I think there's also one of the things, as well as preventing that sort of technique for trying to prevent that happening. I've also had that happen where I've had a bougie that's not been that's been too flexible, and it's sort of buckled as you're railroading the tube, and the tip of it is flicked out of the trachea into the esophagus, so that you have actually got a good view of the trachea, of the larynx, and you have put the bougie in the trachea, but it moves during passage of the tube. So another recommendation I didn't go through there, as I said, that again, just encouraging everyone to read the guideline, because there are additional recommendations in it that I haven't gone through, but one of them is that once the tube's been passed, we advocate that people actually then take a moment before withdrawing the laryngoscope. I often see my trainees, they'll put the tube in, and then the tube goes in and the laryngoscope comes out all in one thing, and is that once the tube's passed, they take a moment to just again go through that same process I identified when doing a repeat laryngoscopy, but once they've passed the tube, to just look and say, can I see the tube now, having passed it, sitting between the cords and anterior to the arytenoids, rather than, as you say, just seeing the larynx and then putting the tube, but actually assessing afterwards to make sure that the tube actually has been delivered to the right place.
Fantástico. No sé si hay algún otro comentario. Me gustaría mucho escuchar alguna opinión del doctor Carlos Reyes, que es un anestesiólogo chileno con una tremenda experiencia y dilatada trayectoria tanto en la docencia como en el manejo de pacientes de urgencia. No sé si Carlos, estás por ahí. Mientras esperamos a Carlos, me parece importante, Nicolás, que se mantenga la promoción del uso de la capnografía, tanto en los servicios de urgencia como en las unidades de cuidados intensivos, que en general, y especialmente en nuestro continente, no existe la cultura del uso de la capnografía. Creo que estas guías de PUMA pueden contribuir de buena manera a estimular que en las UCIs y en los servicios de urgencia exista la capnografía, tanto para el diagnóstico de la intubación esofágica o por otro lado la verificación de la intubación traqueal, como en el monitoreo del paciente ventilado de manera invasiva. Esto me parece tremendamente relevante. Yo sé que hay una iniciativa, especialmente en África, donde ha habido una campaña de donaciones para que los servicios de países africanos con menos recursos puedan tener disponibilidad de capnógrafos. Yo siempre he echado de menos el uso de la capnografía en las unidades de cuidado intensivo y los servicios de urgencia. Creo que es una parte importante, como un rol que nosotros podemos tener en la promoción de estos conceptos que tú has vertido hoy día, que permiten mejorar la seguridad en el manejo de la vía aérea. No sé qué piensas, Nicolás.
You're very welcome. Hopefully, as the rest of the PUMA guidelines come out, I'll get the opportunity to speak with you again. And thank you also for being part of our advisory group, because that consultation with people like you all around the world has been very useful for us to make sure that the guidelines, both these guidelines and all the other ones that are coming, are relevant to all clinicians in all disciplines all over the world.
Perfectamente. Una pregunta que yo quería hacerte, Nicolás, es ¿qué te parece acerca del rol de la ultrasonografía durante la intubación? Porque tú mencionaste que la ultrasonografía podía ayudar a detectar la intubación esofágica cuando uno ve en la pantalla que se forma un segundo lumen, fuera del lumen de la tráquea, un segundo lumen que indica que el tubo ha entrado en el esófago. Y eso posiblemente sea precoz, o sea, más, un indicador más precoz que la capnografía de la intubación esofágica. Creo que hay algún estudio sobre eso y que indica al respecto. Nosotros en muchos servicios estamos usando la ultrasonografía para diferentes procedimientos, ya sea de bloqueos nerviosos, como la instalación de vías vasculares, de accesos vasculares, pero no tenemos una cultura que nos indique una utilidad de la ultrasonografía en el manejo de la vía aérea, y creo que esta puede ser una buena oportunidad para poder, digamos, difundir el concepto del uso de la ultrasonografía durante el proceso de intubación.
Yeah, look, I think there's probably a role for it. I think I certainly wouldn't advocate it as an alternative to capnography, but as an adjunct to capnography. I think what capnography gives us, you know, ultrasound in terms of esophageal intubation will tell you the position of the tube. Capnography tells you that you're ventilating, you know, so the tube can be in the right spot, but blocked. The capnography gives you a lot more information about ventilation, and is also obviously relevant to airway management when you're using a supraglottic airway or face mask. So there's no question of the absolute importance of capnography, but certainly ultrasound as an adjunct is useful. But again, you have to have the equipment, and then you probably need another person to hold it. So I think that they probably become constraints. I think one of the advantages of doing that in a routine setting is that it familiarizes people with what they're supposed to see, is that when they need to check it in the context of how I've outlined in the guidelines, that they're familiar with what they're seeing. So I certainly think there is an increasing role for it. I think that one of the things that I'm cautious of with ultrasound is using it, you know, I think in terms of going broader than esophageal intubation, I think it has a role in marking the position of the cricothyroid membrane when you're concerned preoperatively, but it has a potential value, as we've discussed, in identifying tracheal intubation. I think where it has less of a role is in the emergency situation. In you know, while we're advocating it here, where we're advocating if it's available. If it's going to cause a delay, then you can't do that check, then we would advocate just as a precaution removing the tube. And similarly with performing neck rescue techniques, I don't think there's a role for it in real time. If you had a can't intubate, can't oxygenate scenario in using ultrasound in real time, I think there's, you know, in terms of accessing the ultrasound, often they take time to start up the machines and then getting a view. I think they could potentially delay important interventions. But there's certainly, I think in the preparatory setting, there's certainly a role for it.
Perfectamente. Muchísimas gracias, Nicolás. Creo que ha sido una jornada tremendamente valiosa para todos nosotros, porque puesto que este es un tema tremendamente importante y hay una campaña acerca de esto. Hace un tiempo atrás se realizó un webinario internacional a nivel global, organizado por todas las sociedades de vía aérea del mundo, que dirigiste tú, y junto con otros 8 grandes expertos que hablaron sobre este tema en 2 días seguidos, y que fue tremendamente interesante. Quiero mostrarte y mostrarles a todos desde dónde nos ven. Esto es un mapa de conexiones desde del año pasado, del año 2021, y quiero mostrarles a continuación desde dónde nos están viendo hoy día.
Wow.
donde estamos viendo hoy día, donde los colores verdes señalan cuáles son los países donde más nos ven. Y los colores amarillos, los colores rojos donde menos nos ven, posiblemente hay menos personas de habla inglesa, ya sea el país que más nos ven es Perú, y seguido por Venezuela, y en toda Latinoamérica nos están viendo, como tú puedes observar, inclusive en algunos países de Europa, incluso sorprendentemente debe haber algún latinoamericano en Rusia, y en esos países tan lejanos. Así es que estamos muy orgullosos del avance que hemos tenido en la cobertura que ha tenido este webinario. También quiero contarles que estamos en redes sociales, en Facebook, tenemos casi 600 seguidores, lo mismo que la Facebook del programa de anestesiología. También tenemos un canal de YouTube, donde están todas los webinarios, y ustedes van a poder acceder al webinario del Dr. Chrimes próximamente de manera gratuita, sin ningún requisito especial. También estamos en Instagram y en Twitter. Quiero anunciarles que el próximo webinario que vamos a tener el próximo sábado 26 de noviembre, vamos a tener también, como lo tuvimos hoy día, el privilegio y el honor de contar con el Dr. Chrimes. Vamos a tener el privilegio y el honor de contar con el Dr. Tim Cook, que quizás muchos de ustedes lo conocen. Ha sido un gran promotor de muchas de las guías que se han desarrollado en los últimos años, y fue el gran motor del estudio NAP4 que se hizo el año 2011 con relación a las complicaciones relacionadas con el manejo de la vía aérea, que causó un tremendo impacto en todo el mundo, y que muchas de las estrategias que hoy se manejan nacieron justamente desde ese estudio. Entonces el Dr. Tim Cook nos va a hablar acerca de los 10 u 11 años que han transcurrido desde el estudio NAP4, y la pregunta fundamental es si hemos aprendido la lección. Entonces los quiero dejar invitados desde ya. Recuerden que el acceso es directo, sin ninguna inscripción, y les ruego que por favor verifiquen su hora local. Esto es a las 10 horas de Chile, pero hay muchas veces cambios de horario por las estaciones, y les recomiendo que verifiquen su horario, su hora local. Pueden usar este código QR en un sitio web o cualquier sitio que ustedes elijan para poder verificarlo. Así que les agradezco muchísimo. Entonces, en nombre del programa de anestesiología y reanimación de la Universidad Diego Portales, le damos las gracias al Dr. Nicholas Chrimes por el esfuerzo, la gentileza, el tiempo que ha tomado de su descanso, de su trabajo, para poder dedicarnos a nosotros este importante tema hoy día. Nicolás, un gran abrazo desde Chile. Esperamos tenerte también por acá próximamente. Por supuesto, aquí, como tú ves, en Latinoamérica, el Vortex ha sido ampliamente discutido junto a otras iniciativas que tú has tenido durante todos estos años, y que te han transformado en un gran aporte para la seguridad y la calidad en el manejo de la vía aérea de nuestros pacientes. Así que, Nicolás, muchísimas gracias.
Thank you, Ricardo. I'd love to come and visit now that the world's opening up again.
Exactamente. Bueno, muchas gracias a todos. Voy a dejar de compartir la pantalla. Eso es. Que tengan un gran día. Muchas gracias. Un gran abrazo.